this afternoon. We appreciate you all for coming to hang out with us and learn about our new crisis policy. We have Chris Ann Taylor as a social service program specialist here with Nevada Medicaid, and my name is Lori Follett. I'm the chief of the medical behavioral health unit. Thank you guys all for coming. My apologies again for our technical issues as we came into this meeting. We are at 1:07, and I'm going to go ahead and turn it over to Chris Ann. The format today, we'll go through the slide deck, give you the overview of the policy, and there will be time for questions and answers. But Chris Ann is going to lead you through everything crisis.
Awesome. Thank you, Lori. Good afternoon. Again, my name is Chris Ann Taylor. And like Lori said, I'm a social service program specialist with Nevada Medicaid. Today, we're going to review some proposed updates and additions to Nevada Medicaid's crisis policies. As Lori said, this meeting is being recorded. You can also find the link to all the documents and the slide deck on our public notices website. Although it appears we're having technical difficulties at the moment with it, hopefully it'll be back up soon. But that's where all the documents and this presentation are located. So before I begin, I'd like to take a moment to express our heartfelt gratitude to our many stakeholders who have generously shared their expertise and shown unwavering support in the creation and revision of our crisis policies. Your ongoing collaboration and feedback is invaluable to ensure we get it right, or at least as close to right as we can be. You are the ones with boots on the ground, helping Nevadans navigate crisis situations, and we appreciate it. So here's our game plan for today's workshop. First, start with a brief introduction to Nevada Health Authority and Nevada Medicaid. Then we'll review the proposed removal of crisis services from Chapter 400 of the Medicaid Services Manual. After that, we'll look at Chapter 4400, Crisis Services, and the new crisis specialties for Provider Type 87. Finally, we'll open the floor for public comment and questions. As I go through my presentation, feel free to enter any questions in the chat and we'll address them, hopefully, at the end. So the Nevada Health Authority, or NVHA, was established during the 2025 state legislative session. NVHA's mission is to ensure access to affordable, reliable care by leveraging the state's buying power, streamlining programs and services, and driving better quality and more innovation in the healthcare system, while staying true to the values of public service, fiscal discipline, and accountable leadership. Nevada Medicaid is responsible for administering the state's Medicaid program, which provides healthcare coverage to about 1 in 4 Nevadans. Our mission is to purchase and provide quality healthcare services to low-income Nevadans in the most efficient manner, promote equal access to healthcare at an affordable cost to the taxpayers of Nevada, restrain the growth of healthcare costs, and review Medicaid and other state healthcare programs to maximize potential federal revenue. With the creation of Nevada Health Authority, DHCFP, or the Division of Healthcare Finance and Policy, is now officially called by its common name, Nevada Medicaid, which is so much easier to say. As a reminder, don't forget to update all your Nevada Medicaid contact email addresses to reflect our new NVHA domain instead of the DHCFP. All right, to begin. So today's workshop is to discuss transitioning Nevada Medicaid's crisis policies from the existing Medicaid Services Manual, MSM, Chapter 400, which is for mental health services, to the new chapter, which will be dedicated to crisis services. We believe that dedicating a specific chapter to crisis policies will improve accessibility and it'll enhance the ease of access for both providers and the public. During this transition, additional revisions have been made to ensure clarity and uniformity. Throughout the chapter, grammar, punctuation, and capitalization changes were made, duplications removed, acronyms used and standardized, and language was reworded for clarity. Renumbering and rearranging of sections was necessary to make the policies more understandable and consistent. We also updated all references to DHCFP and replaced it with Nevada Medicaid. And most all references to patient or member were replaced with participant for consistency. So these are our existing crisis services that are currently housed in Chapter 400 of the Medicaid Services Manual. Crisis intervention, designated mobile crisis teams or DMCTs, which includes CCBHCs delivering mobile crisis as a DMCT, and our crisis stabilization centers. We are proposing to relocate all of them to our new crisis policy chapter. In addition to moving crisis services to their own dedicated chapter, each section will follow a consistent format and layout to enhance readability. Each section of the new MSM chapter will have a summary or introduction section, which describes the crisis service at a high level. The eligible provider section covers everything from enrollment guidelines and provider supervision to training and documentation standards. It also covers quality assurance, operational requirements, and best practices. Under eligible members, we list who is eligible to receive the crisis service. Covered services explains what services are covered and which are considered essential. Non-covered services is pretty straightforward as it lists the services that are not covered by Nevada Medicaid. Authorization requirements advises when a prior authorization is required. And finally, we have the billing section that includes the billing guidelines and rules, as well as the applicable billing chart. Also being added to the new chapter are 2 appendixes, which we'll review in more detail later in this presentation. So up first is crisis intervention. In addition to being moved to Chapter 4400, we made a few minor additions to add clarity and to reflect policy updates. The summary section was expanded to include a better description of crisis intervention services. Eligible providers was updated to reflect policy on crisis intervention being delivered by an individual versus a team approach. And additional language was added for clarification of non-covered services, and new sections were added for authorization requirements and billing guidelines. Next is our designated mobile crisis teams, or DMCTs. To deliver mobile crisis as a DMCT, a provider needs to be a governmental agency or a provider of emergency medical services and be enrolled under provider type 87, specialty 31. We've added clarification that providers of emergency medical services like ambulance, fire, or search and rescue are eligible to enroll as a DMCT under PT 8731. Please keep in mind that if a DMCT also wants to provide transportation to another more appropriate crisis provider, for example, to a crisis stabilization center, then they'll need to enroll under the applicable transportation provider type. The DMCT is led by a licensed behavioral health professional, like a QMHP or a QMHA, under the supervision of a QMHP. And the remaining team members can consist of other behavioral health professionals, paraprofessionals, peers, and providers of emergency medical services. We've also added clarification on the temporary QA/QI component and provided a guide to assist providers in the development of their respective programs. A small section was added to better explain the policy for CCBHCs who choose to deliver their mobile crisis as a DMCT. The key point being that CCBHCs may bill their mobile crisis separately and in addition to their CCBHC PPS rate when they also enroll as provider type 87, specialty 32, and follow all the DMCT policies. For example, if a CCBHC doesn't want to provide mobile crisis following all of the DMCT policies, then their mobile crisis would be included as part of their daily PPS rate and could not be billed separately under the DMCT model. The final existing or current crisis service being transitioned to the new chapter is our Crisis Stabilization Centers, or CSCs. They are hospital-endorsed facilities providing intensive crisis stabilization services following a delivery model of 23 hours and 59 minutes. A significant portion of the updates to this MSM section involved relocating policy details from its previous billing guide and enrollment checklist. Provider supervision, additional information was added regarding the team structure and clinical supervision. Provider training was added to ensure consistency between all crisis providers. Operational requirements, details were added on the alignment of evidence-based practices and documentation standards. It also provides clearer directions on screening and assessment tools, safety plans, coordination of care, including the use of MOUs or Memorandum of Understanding, best practices, as well as privacy and confidentiality protocols. Before we continue, let me show where all those changes that we've discussed so far are located in the new chapter. Give me just one moment while I switch out of the presentation. All right, can you see it okay?
Can you make it a little bigger, Chris-Ann? Can you zoom it a little?
I can try, it kind of goes off the screen if I go to.
Okay, you're good. Go ahead.
Okay, sorry. All right, so please keep in mind that everything listed in green is policy that was moved from chapter 400 over to the 4400. Text in red is new policy, and text in red strike through is policy being completely removed. Chapter 4400 begins by listing the various authorities that impact crisis services. Then we list a few definitions that are not listed in our MSM addendum, but are relevant to this chapter. We added a small section relating to managed care members. Then we have our first crisis service, crisis intervention. As you can see, not much has changed, and most of the additions were for clarity, as well as adding a new authorization and billing sections. Up next is our designated mobile crisis teams. In the summary section, we added verbiage to better explain the two different types of DMCTs, Specialty 31, which is for our governmental agencies or EMS, and Specialty 32, which is for our CCBHCs. We added direction on the temporary quality assurance and quality improvement program, as well as additional languages added to include medical record standards. And then here is the new section that we added to explain the CCBHCs delivering their mobile crisis as a DMCT. And just like all the other crisis services, there's a new billing section that includes the billing chart for both specialties. Now we'll jump to our Crisis Stabilization Centers. As I said earlier, most of the updates to the CSC policy were to incorporate policy details that were not in the MSM, but were located in the provider enrollment checklist or the billing guide. The eligible providers section was expanded to include clinical supervision requirements, as well as staff and training standards. We also added clearer operational requirements and the use of evidence-based treatment practices. A privacy and confidentiality protocol section was added to align with our other crisis services. Under covered services, all the essential services were listed for clarity. The essential services are the minimum services that a CSC must provide to utilize their per diem rate. A non-covered services was added. And in the billing section, we added additional details to explain the default daily rate, the shadow billing requirement. We also included details on their option to choose a cost-based daily rate, keeping in mind that once they choose a cost-based rate, they can never switch back to the default daily rate. Now I'm going to go back to the presentation and share the new policies. Just a moment. All right. All right. Now we're going to take a look at our new crisis services, the Mobile Crisis Team and the Intensive Crisis Stabilization Service. Mobile crisis teams, or MCTs, are community-based teams that provide mobile crisis in a designated coverage area. Most of the MCT policy closely mimics the DMCT policy with a few exceptions. As they are not a governmental agency or a provider of emergency medical services. They can, when clinically appropriate, deliver mobile crisis with one person responding in person. Also, with the recent passing of AB 380, law enforcement is an allowable team member when necessary or appropriate. MCTs must provide 24/7 coverage, but it can include on-call coverage. For example, if the main operational hours of the mobile crisis team is from 6 a.m. to 10 p.m., they can ensure they have 24/7 coverage by having personnel available to answer their phone calls and receive dispatch requests between the hours of 10 p.m. and 6 a.m., with clinical and behavioral health staff on call to assist with dispatches during those hours. Up next is our Intensive Crisis Stabilization Service providers. A mouthful. ICSS providers are very similar to our Crisis Stabilization Centers, except they are not a hospital-endorsed facility. They are a community-based facility that promptly conducts a comprehensive assessment and develops a treatment plan focused on crisis intervention. ICSS providers must perform an initial assessment on all patients, regardless of their age or severity of their behavioral health issue. They also need to have the necessary equipment and personnel to conduct medical examinations and clearance. ICSS aftercare coordination must include at least one follow-up contact within 72 hours of discharge. ICSS providers, like our CSCs, are reimbursed using a default daily rate. Once they complete their first full year of operation, the default daily rate is updated annually based on the Medicaid Economic Index, or MEI. ICSS providers may request a cost-based rate after their first year of operation, again, without an option to switch back. They can use the default daily rate when they have delivered all the essential crisis services. When they're unable to complete all the essential services, they can utilize the Crisis Intervention Billing Code H2011 for the time that the participant was in their care. For example, a minor comes to an ICSS facility that doesn't have the staff or environment to treat children. They are still required to perform an initial assessment to help determine where the child would be best served and transfer them to that provider. In this instance, the ICSS would use the H2011 code for the time it took to complete the assessment and transfer the child to a more appropriate provider of crisis intervention. So, to qualify for the default daily rate, they must deliver all of their essential services, which are listed here. Crisis intervention, which is the immediate care to de-escalate and stabilize the situation. Services might include evaluations, screenings, assessments, therapy, testing, and more. Initial and comprehensive assessments are to evaluate the individual's mental health, substance use, and co-occurring conditions. Observation and monitoring during their stay to ensure the individual's safety and stability. They deliver a treatment plan tailored to the individual's needs and diagnosis. Case management services include, without limitation, services to assist in obtaining housing, food, primary health care, and other basic needs. They offer referral services to connect individuals to ongoing treatment and support systems. They also provide medical clearance to ensure individuals are medically stable. And in addition to discharge planning, ICSS providers are required to provide at least one follow-up contact with the participant no later than 72 hours after being discharged. All right. Now our new additions, Appendix A is the quality assurance and quality improvement component. This has been added until DPBH certification is obtained. Providers will have 90 days to initiate the process once DPBH has completed the certification criteria and it's ready for enrollment. A quality assurance and quality improvement program is a structured approach that organizations use to enhance processes, systems, or services over time. The goal is to create an environment where improvements are ongoing and driven by data, feedback, and collaboration. Appendix A was created to assist providers with the creation and submission of their QA/QI program report. It provides key components necessary, data collection, and links to other resources to develop a successful QA/QI program. Lastly is our Appendix B, which is a Memorandum of Understanding Toolkit, which is designed to assist all crisis providers in establishing successful partnerships with other crisis care providers. A key element in delivering a comprehensive crisis response is the development of partnerships formalized through Memorandum of Understandings. Partners should include local community-based organizations, law enforcement, emergency medical response, fire departments, community health centers, hospital, and many more. Now we're going to take a look at the new services and the appendixes. Let me get out of the slideshow just a moment. All right, this one is gone. There. All right. So as a reminder, these are all new services. So everything for these two services are in red font, but they also follow the same layout as the previous three sections. Starting with our mobile crisis teams, we have the summary and then the eligible provider section, which includes provider supervision, staffing, training, again, to match up with the other crisis providers. Then we have our quality assurance and collaborative protocols and other operational requirements. Then we have our sections covering eligible members, covered services, and non-covered services. And finally, the billing section with the applicable billing chart. Sorry for some of these pages being like that. All right. So last but not least is our Intensive Crisis Stabilization Service, starting with the summary section. Then we go on to our eligible providers section, which covers a lot of information. There are guidelines on provider supervision, provider training, and other operational requirements. We also included collaboration protocols with the use of MOUs, as well as details on the quality assurance component. Then we have our sections covering eligible members, covered services, which also includes their list of essential services. Then there's non-covered services, and finally their billing section. Oops. Now I'm going to show you the appendixes. So looking at Appendix A, let me get this over here. There we go. Can you see both pages?
Yes.
Yes. Okay, good. Thank you.
Yes.
Thank you. All right. So The Appendix A assists with developing a quality assurance and quality improvement program. It provides key components to consider, the type of data needed, and it has a template of questions to assist with the outline of a successful QA/QI program. Remember, this requirement is only in place until DPBH completes their crisis certification programs. And at that time, they'll have 90 days to begin the certification process. Appendix B, here we go, lists best practices to assist providers with developing collaborative agreements or MOUs with other crisis care providers. An MOU acts like a roadmap for collaboration, defining shared goals and the authority and responsibilities of each partner. It also clarifies decision-making processes, conflict resolution methods, and data sharing agreements to ensure compliance with HIPAA and FERPA. Both appendixes also provide links to SAMHSA and other related resources at the end. Just a moment. There we go. Too many screens. All right. Here we go. All right. Here we go. Whew. All right. So this concludes my presentation. I've covered a lot of information. Again, a copy of this presentation is on our public meeting page, if it's available right now.
It's available, and I've already put it in the chat. It's available and it's in the chat. Yeah.
Okay, perfect. All right. So if you have any questions, comments, suggestions, or anything, feel free to raise your hand or use the chat option if you'd like. I'm going to stop.
There is a question in the chat, Chrisanne. Steve, I will try and encompass that, but if I get it wrong, feel free to come off mute. Can a non-hospital community-based organization that provides intensive crisis stabilization services also provide and bill for other distinct services such as inpatient, outpatient, PRTF on the same property or under the same roof, as long as the services are appropriately licensed? Sarah, I don't know if you want to jump in there.
Sure. Thank you, Steve, for that question. I think this is this question is being memorialized for sure. So we're still talking those small pieces out and can have clarification for you later on that. We have met internally with our healthcare quality and compliance team because we want to make sure we provide the best guidance on facilities that function with multiple types of care. But our initial conversations with CMS is that is looking positive. So I know that's not a very technical answer, Steve, but we'll certainly follow up with you and your team.
And then Nancy, if you'd like to go next, and then we'll address another question in the chat.
Hi, thank you. Nancy Brooks from the Clark County School District. I'm the Medicaid coordinator. And, you know, our Bible is always chapter 2800, but of course we refer back to other chapters, back to 400, and then now the new 4400. I didn't see a whole lot in there that affects our policies and procedures, but I just wanted to make sure there wasn't something that I was missing.
Only as it relates to maybe crisis intervention, maybe, is what I would think. The rest of it, yeah, no.
Okay, thank you for confirming.
Not a problem. And then in the chat, we got, is there a set definition for designated call center? So Sarah, correct me if I'm wrong. We're pretty much, that would be, it could be 988 and or 911. Or they might even have their own internal call crisis line as well.
Julia, you have your hand up. Do you want to come off mute?
Hi, thank you. Um,
Hello.
My question is if there's any I really have two questions. So first question is, and I'll wait in line for the second one. Regarding the 23 hours and 59 minutes,
Mhm.
is there any willingness or appetite to review that? I think the concern that we have locally is in the holes that we have in our continuum of care, that the reality of getting somebody assessed, stabilized, particularly if they also have detox, where you have to wait for a period of time for that process to move through,
Mhm.
to get somebody stabilized, assessed, find an appropriate placement, and do a warm handoff within 23 hours and 59 minutes, particularly within the realities of the Nevada continuum of care. Doesn't seem like we will be successful. And then I'm concerned about the viability of the model if you can't bill, if they're staying for a second day, but you can't bill for it. Particularly concerned for children. I think we have pretty broad recognition in our children's crisis response that we're not just talking about a sub 24 hour. And our children's mobile crisis teams, definitely when they're doing a crisis intervention, they're talking about weeks, a little bit different, but particularly for our crisis stabilization centers, children for sure, I'd throw in adults. Could we please talk about expanding that 23 hours and 59 minutes to 72 hours?
As far as what the guidelines are because of the SPA and CMS guidelines in regards to it, for this particular service, we're pretty well tied to the 23-hour and 59 minutes. Now, doesn't mean we can't come up with another alternative service, but unfortunately that's not today. But it's definitely something we can discuss, because I agree that we definitely need something else that's kind of in between the short term and then the long term, somewhere midterm. But yeah, that's something that would have to come with more discussion, and it would be a completely different service.
Thank you,
Yeah, and
Chrissy. And just to add on to that, sorry, Julia.
No, go ahead, sir.
Just to add on to that, Chrisanne is correct. It would require a state plan amendment if we were to change that time limitation. It would be a different type of benefit. But I think as we're working on building out the continuum, building additional services, there's also additional services we're talking about that were passed through Assembly Bill 514, which is kind of that short-term residential space for mental health. I think the more we talk about all these levels of care, we're recognizing what gaps we have and we can plan for the future. So keeping the discussion on the table, but as Chrisanne said, it's not an immediate reimbursement right now. And just seeing a couple questions in the chat as well. The unit is based on a per day unit, so it's per crisis episode. I'll just reiterate that, but yes, future discussions I think are needed as we build this out for Nevada's needs.
And as far as sustainability, I mean, there is it has the per diem rate, which is, it starts off with the default at 600, and then is, like I said, updated annually after their first full year, and then on each July with using the Medicaid Economic Index, the MEI, or hopefully if they keep really good records, and they can prove that, yeah, maybe it does cost more to do, they could do the cost-based option. Depending, I mean, a lot of it just depends on how well they keep their records.
Yeah, I really I want to make sure I'm clear. I really appreciate the both the default rate and the cost-based opportunity. And I really want to express gratitude for having that built in. I think that that's really important. My comment on sustainability is more the reality of a facility is probably not going to discharge somebody who's not stable or doesn't have a meaningful placement. And so then therefore that person staying there 2 days, 3 days, 4 days that they cannot bill. And that's more the sustainability piece that I'm concerned about. So I appreciate it.
Definitely. sorry to interrupt, but definitely agree with you. And it's definitely something we can discuss and look into more. But yeah, definitely need some discussion on that.
Even if there could be something preemptive that you know,
Mhm.
where you're preemptively approved, if you started in a crisis stabilization center, you're preemptively approved for some residential or something along those lines. I don't know, but thank you.
No problem. I'm going to look at the chat. Steve, would an agency with a 911 CRT response qualify for PT 8731 with an LCSW in a dispatch center? I
I
don't
think
know
we
all
might need
the,
a little bit more
Yeah.
information on that, Steve, if you wouldn't mind emailing us
Yeah.
a little bit more about that, about your situation, or you can come off mute unless Sarah wants to jump in.
I'm happy to jump in and just clarify in order to be a provider type 87 specialty 31, at least one team member has to respond in person. It does not have a requirement of what team member that is. So if your LCSW is virtual or via telehealth, and you may have another provider as part of the team that responds in person, that is acceptable. That fits those CMS requirements under that. I'm thinking that's where your question was going.
and that's why the DMCT model has the place of service code. Couldn't think of the name. The place of service code, so that we know that if both went or if one was virtual. Let's see. Jimmy has a question. The Crisis Stabilization Center is unable to stabilize a patient for crisis for 23 hours and 59 minutes. Do we have the ability to use it for day 2 or 3? If not, is there a different code to use? Sarah, do you want to answer that? You do it so eloquently.
I'm not sure I do it eloquently.
I think you do.
Happy to reiterate. So the crisis stabilization code is a per diem code, so it's 1 unit per day. If there are additional services that providers are enrolled under or performing for additional days, like if a provider is additionally enrolled as a provider type 14, for example, and is providing some additional services on additional days, that's certainly a possibility. But for now, as we had just discussed with Julia, it's really the goal is that 23 hours and 59 minutes. That's how the service benefit is built. But it would be up to the provider to determine the appropriate codes if in addition to that. And then Chris Ann, I think you skipped over Steve Shell's question.
Did I?
You had another
Yes, I did. Sorry.
question.
So yeah, Steve Shell's question, the other Steve. Will Intensive Crisis Stabilization Services be licensed by HCQC? I'm not even sure if that's what we're going to be calling. We're still calling them that, right? With all the changes we've had going on. I don't know how to answer that one.
Sure, I'm happy to take a stab at that. Yes, Steve. So eventually, like our mobile crisis teams, the goal is to build certifications out for our mobile crisis teams at different levels, and then also for this community facility-based provider of intensive crisis stabilization as well. That's certainly where we're heading, is really to kind of build better quality around or ensuring that quality of care is provided through that certification piece. So working in partnership with our Division of Public and Behavioral Health on that.
And then Jessica's question also in the chat. So an internal crisis line would qualify for how they get dispatched. I just want to ensure I'm understanding correctly. In addition to, yes, they have to accept calls though from the 988. That is more of the designated. The problem right now is that how that looks with Mercer and the new 988 provider. We're not entirely sure. We're still working with them and DPBH on exactly how all that's going to look. But even 911 dispatches are fine. And then I'll get the last one in the chat and then we'll go to Sue afterwards. So we got, is there a date for when rate increases will be active that were to be effective for peer support? I don't have a clue on any of that stuff. That's not my world.
Happy to take that one.
Thank you.
So this doesn't have to do with our crisis services, but there will be updates, and I really also want to take this opportunity to plug for providers to pay attention to our public notices website. There is the Nevada Health Authority will be putting on a legislative stakeholder workshop on Monday, the 28th. So I encourage everyone to attend that. That'll be super informational on all sorts of information, but specifically regarding some of the proposed rate increases. Nevada is still working with CMS on final approval of some of those rate increases. But I'm hoping, Jess, you may have received the additional information that although there was a public workshop in March on initial proposed rate increases, due to a lot of the uncertainty federally, we had to pull back on some of those rate increases. But as far as peer support, that continues to be proposed for a rate increase. And then as well as your rehabilitative services specific to children's behavioral health is also proposed for some rate increases. So stay tuned on that. That is not approved yet, but those will be retroed back to January 1st of 2025 as well.
Thank you. Sue, if you want to come off mute and ask your question.
Okay, I think I'm off mute. Can you hear me?
I can hear you.
Perfect. I just wanted to follow up on a question on the Crisis Stabilization Center for the per diem that I keep hearing. So for example, if I have a patient that's in a crisis care center on Monday for 12 hours, and then they're on Tuesday for 12 hours. I know I'm close to my thing here.
Right.
Is
So
that 2 per diem rates? So 600 on Monday, 600 on Tuesday, or are we saying that the whole care for 2359 is the 600 rate? What are we saying by per diem? To me, that means per date of service.
per admission, let's say. That's probably sounds
So
better.
it's a
Per
rate.
admission.
So it's just a rate.
Yeah.
Not
Yeah,
a
that's
per
probably
diem.
a better way. Okay. Yeah, that's
Then
probably
I
a
would
better way of saying it.
recommend that be explained a little better, because to me that's very confusing using the term per diem. I think it's just like inpatient with Medicaid. Every day I have my patient in the hospital, I get a rate each date of service. And then I think from the claims perspective, it would be very helpful. I'm guessing, since this will be an outpatient claim and that we're billing on a UB, I'm a hospital-based crisis stabilization center, I would give you each date of service that I have the patient there. And I realize that you're locked into the 2359 and that'll be addressed. But I do recommend that the facilities be allowed to bill the total hours of care so that you can start to have data. You can still choose to give me the one rate, but if I have someone in there for 48 hours, I would like to be able to file a claim for 48 hours and you just give me my maximum rate.
I get what you're saying. And I think and we do have the shadow billing in place, which does allocate, but I will double check that there's not a limit on the amount of that shadow billing time.
Yeah, because it says one unit, 24
yeah.
hours. Yeah. That would be my recommendation, or you're never going to have data if we're not allowed to send you our claims information.
Oh, I like that suggestion. Thank you very much.
Thank you.
All right. Up next, JG. I can't read your whole name. Oh, Jessica, it looks like.
Jessica.
Just popped up. There we go. It was cutting your first name off.
Thank you. I just want to ask, in regard to the staffing for the designated mobile crisis teams, is that also an option for on-call during like those graveyard hours, as long as the hotlines are up and able to respond? Because you mentioned that was mentioned specifically for the mobile crisis teams, but it was not mentioned for the designated mobile crisis teams. And then I have a follow-up question probably.
Go ahead. Yes, please. Yeah.
Yeah, Jessica, so I may need extra clarification. So, so when the crisis line comes into play, that's where I get a little confused. But as far as to qualify as a designated mobile crisis team, if there is a call that comes in and someone is able to respond in person, the key is that there is an in-person response. It has to be available 24/7, 365. If you have a mobile crisis team that maybe, as Chrisanne gave an example of, is open till 10 p.m. and then other than that, it's more of a crisis line or goes to the crisis support services of Nevada, that would not qualify as a DMCT. So it's really the key is being able to respond 24/7, 365 in person.
So I could have an on-call team that could take that response at any time, between, as long as I have a team to respond. I don't have to have a team who is working, because otherwise without this being a very large rate, that's going to be very difficult. Or a daily rate or something like that for, to have teams available where they're not like even on call is going to be, difficult because we're paying them. And we have had one call between midnight and 8 a.m. in the year that Washoe County has had mobile crisis that we've responded to. And that, that is with our hotline being open 24/7, 365. And now, I have the data now for us anyways for a full year, which is great. But that's one call. And so I'm having teams available and paying them. And that makes it just a very difficult thing to sustain as an agency, even a government agency, or maybe especially a government agency right now. So just something to think about. And
well, and like Sarah said, though, the key with the DMCTs is that it has to be an in-person response. So as long as you're able to deliver that, I don't see a problem with what you're describing.
Yeah, I think just maybe if you guys can think about the rate, understanding that we are going to have to staff somehow 24/7 and very, very, very seldom actually using those people, but we still have to pay them, whether they're on a response or not. And that's
and agreed. And that's the hard part with all the crisis services. I totally understand that. And it's trying to find that balance. Yeah.
Yes. And I would just add, Jessica, absolutely. And I know Julia has her hand up and she could probably say that so much more eloquently, but I know she's been talking about this ever since we've even been talking about really making our Medicaid crisis system a bit more robust. So I will just add that during legislative session, Medicaid did include some funding for mobile crisis rate reform that obviously our budget just got passed about a month ago. So we're still kind of in the initial phases of that, but we definitely have heard that from you all about the rate. So we look forward to some rate reform, but right now it's really based on that H2011 code.
And I understand. Like the DMCT has the enhanced rate, which I get still isn't probably where you'd like it, but at least for now, it is for the DMCTs where the mobile crisis teams don't have that enhanced rate. So, Julia.
Thank you. Following up on Jessica with specific questions about designated mobile crisis teams and community-based mobile crisis teams. Can you just talk a little bit about that billing and when it kicks in? Like we've got geography, we've got all the issues, right? So is it from Is it in 15-minute, excuse my ignorance, but is it in 15-minute increments? Is it from the moment that that team is dispatched, even if it takes them an hour, or I'm just looking at some of my rural colleagues on the phone, 4 hours to get there? You'll be able to bill all that time. If the call gets turned around, like the individual cancels or they can't be located once they get there, do they still get to bill the time that they got out there? And where is all that written down so that it's relatively clear if you're a mobile crisis team that you can, what you can and can't bill for? My concern is that they're only going to bill for the time that they are quote unquote hands-on with the patient. And that's not going to account for time it takes to get there, those calls where you just can't find the person or they get turned around, all of those sorts of things. So is that written down anywhere? Should it be written down here?
Well, the part you mentioned about if they get a dispatch and no one's there is, no, it's not. So that's a good point you brought up. So we can definitely look at that and have more discussions on that one, because that's a very valid point. Shoot, my brain just went poof. The other part was
Transport time, return time from the transport.
Well, yes, I'm pretty sure it's from dispatch, but I don't know if it ends at, I'd have to double check how it actually
ends at
ends.
return
Sarah?
to base, or at the, now you're at the
Yeah.
next, you got a new call, whatever the ending point is.
Sarah?
So Medicaid is reimbursing for the actual service delivered. So the crisis intervention of the mobile crisis team is what can be billed for. So I think as we think about this, and you've been along this road with me for years as we're working to make this better, I think these are definitely things we can think about, and really including not only Medicaid, but also others in the discussion. And I'm not sure, somebody took over sharing the screen, so I'm not.
Yeah, I don't know what that is. Lori, is that you?
No.
So you can
looks
see
like
her name on the bottom.
Alyssa. Let me figure
Alyssa?
out. Yeah, let me see if I can take the screen back.
Not sure how to stop sharing that. Okay. Okay, good. Thank you.
There we.
So Sarah, just what is it currently? Do you when you say it's only for the actual service, is it truly just the time that they are with the patient?
Yes, but would that include, and I don't know, you probably know this better, but if a mobile crisis team, so crisis intervention can be delivered via in-person telehealth through the audio only means, is the intervention taking place on the way to the individual? Does that happen? Also, there's some other components to think for that transportation piece as far as other provider types that kind of might make this response more of a whole response. And we can also think about, as we make this better, as we move forward over the years, how to make this more of an inclusive model of all of that. But currently, right now, it is for the direct service to that individual.
Thank you. And then my follow-up. Well, go ahead. I'll let somebody else take a shot and then we'll go from there.
Okay, well, there's another one from Steve. Would the DMCT still have to meet the urban 1 hour, 2 hour rural response 24 requirements 24/7, or only during their operational hours? They would still have to meet that, but it is an average. So perhaps during their operational hours, they're quicker to help make up for some of the time when they have to actually call the whoever's going to go out on the dispatch in to go take care of it. So that's why it's an average. And then I think we also designated 3 hours in the frontier areas. Hopefully that answered your question. And then Sue, was it? Do you have follow-up? I don't see any others in the chat.
Wasn't Sue. I think it may have been
Was
Jessica
it,
or,
oh, maybe, I can't remember now.
I believe
don't
it was
see any more.
Julia who had to follow up.
Okay, Julia?
Yeah.
So the question is about, so first of all, I will say what I think you wanted me to say earlier, Sarah, that we need a subsidy model for uninsured, for calls that get called back where you don't even know whose insurance there is. Like, I think we know from other states' experience that we can't expect Medicaid billing to carry the entirety of a mobile crisis model. We have for-profit insurance, we have, Medicare, but we also just need a subsidy for those calls that get turned around and those calls that get that people just don't have any insurance at all. So I'll say that it can't all be Medicaid, but we appreciate Medicaid's efforts.
Well,
Which then,
thanks for saying it.
you're welcome. So which then gets me to, when is the trend, or is there any conversation at all? Because the one consistent, wonderful mobile crisis teams that we currently have available are our children's mobile crisis and our, in Northern Nevada, most teams, which both currently have a more of a general fund model of funding, where they just get a blanket amount of money to be able to build the teams and provide the services through sub-grants from the state. And so I know that those sub-grants don't come from Medicaid, but is there any conversation yet about when these rates become available and how much longer they will still be general fund funding, or that, grant funding model, to make sure that we don't accidentally kill the mobile crisis teams while transitioning to a reimbursable model? Or is there even a plan to transition those particular teams to a reimbursable model?
Sarah, do you want to add there? Too much history on that one.
I think that's still, a definite discussion item with all involved. I'm hoping that some of these conversations can be used as we have some funding for that mobile crisis rate reform. But again, I think it really is going to include all of the work of our crisis providers, but Division of Public and Behavioral Health and their new contractor as well. I think that other states are probably doing it differently than Nevada, maybe even better, and we could kind of learn from how their models are forming. But I think all can be added to the discussion as we move forward, but I don't have an answer for that.
I appreciate it. I will just keep making that statement everywhere I can, that I
Thank
plea
you.
that we don't
Thank
dismantle the existing services just because there's all of a sudden a reimbursable model that isn't tried and tested. Thank you for the time.
No problem. No, thank you. Thank you. Appreciate your input. I think I got all the questions in the chat. Lori, did you notice if I missed any?
I think you got them all. It's been a team effort in the chat. You guys have been super active, and we appreciate your input on this. If there's any more questions or comments, you can definitely send those to us. I did put the email address in the chat, but I will move it down to the bottom just in case someone moved on to this call after the fact. But there is, let's see, there's one more. Is there a discussion for revising the 24-hour requirement for DMT services is what it says. So DMCT services.
Yeah, I'm guessing, Laura, you mean DMCT.
Yeah.
Again, on the DMCT policy, there's certain components that we don't have a lot of flexibility with at this time because of the way the SPA was written and CMS requirements. So unfortunately, at this time, the 24-hour requirement's in place. Again, it's something that we might be able to discuss in the future, but at this time, yeah, it's the 24/7 requirement.
And just to add on to that, Chris Ann, so Chris Ann's correct. We don't have any wiggle room on the DMCT model for the 24-hour in-person response requirement, because that is an opportunity provided to states by CMS. But recognizing that that's not how our state functions entirely, that's why we built more opportunity for provider type 87, specialty 33, which is mobile crisis team, simply put. It doesn't have that enhanced rate to it, but there is more to come as we kind of look at our mobile crisis rates too. So there is still opportunity to enroll.
Julia.
I'm sorry.
Hey, that's okay. We like this interaction. It's great. It's better than sitting
Let's
here
just
just in silence.
let's just say there's an EMS provider that is a community-based provider as opposed to a government EMS. Could they choose whether they want to be a DMCT, which includes government and EMS, or they want to be just an MCT, which includes community-based, if they are a nonprofit community-based EMS provider, which happens to be our model in Washoe County, where our EMS provider is a nonprofit that is under franchise agreement with the government, but is not the government.
Well, and I don't think the nonprofit portion really comes into play as long as they can meet the rest of the criteria for the mobile crisis team. I believe so, right, Sarah? I don't, because I mean, we've added verbiage that EMS is allowed on the MCT team as well. They would just have to make sure that they had, you know, the proper QMHP or whomever that's in charge of or responsible for it. But I'm thinking yes.
That they could be either. Perfect. Thank you.
Yep.
Yes.
I'll give it another minute or so in case someone has any questions, thinks of something. But again, you can always shoot us an email as we're going through this. Any other suggestions? Because you guys brought up a lot of really great ones that didn't even cross our mind. So again, that's because you're out there actually doing it. So we appreciate it. I don't see any activity. All right. Well, thank you for allowing me to present and share our crisis services with you. If you think of any questions later, or if you'd like to submit a formal comment, please reach us through the behavioral health inbox. And thank you again for joining us, and have a wonderful rest of your day. Thank you.
Thank you.
Thank you.